Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and wonderful audiences in different parts of the world. Welcome back to ACNS webinars. The speaker for the first session of today is our honorable guest from Italy, Professor Giorgio Lorusso. Professor Lorusso is the director at the Munari Surgical Center for Epilepsy and Parkinsonism, Niguarda, Milan, Italy. He is a renowned figure in the world of epilepsy surgery, and he has contributed to the birth of epilepsy surgery in Grenoble and Milan. He is a noted author, and his works on SEEG and FCDs have been cited widely across the world. He is also an educator and is an invited faculty to several conferences and workshops around the world. We are extremely honored to have him today at our webinars, and today we'll be talking about surgical approach to Opercular insular epilepsy. The speaker for the second session of today is our honored guest from India, Professor Ashish Tandon. Professor Tandon is the Chief of Neurosurgery at the Aditya Super Specialty Hospital, Jabalpur, India. He was a previous skull-base and neuro-oncology fellow at the Toronto, Western Canada, and he did his MIS Neurosurgery Fellowship under Professor Charlie Teo. He did his Spine Fellowship at the Technical University of Munich, Germany. He is the author of 20 peer-reviewed articles and 2 book chapters. We are extremely honored to have him today at our webinars, and today we'll be talking about Uniportal endoscopic lumbar decompression and discectomy basics and videos. The chair for the first session of today's webinar is our honored guest from Japan, Professor Masaki Iwasaki. Professor Iwasaki is the director of the Department of Neurosurgery, National Center Hospital, National Center for Neurology and Psychiatry, Tokyo, Japan. His research and practice are primarily focused upon epilepsy surgery. He is an important member of the Japanese Epilepsy Society, American Epilepsy Society, and International Society for the Advancement of Clinical MEG, and he has been honored with several awards and honors for his outstanding achievements both in national and international conferences. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is another stalwart in the field of endoscopic spine surgery, and he is none other than Professor Hyun Seng Kim from Korea. He is the director, Department of Neurosurgery at the Nanori Hospital, Gangnam, South Korea. He was the president of the Korean Research Endoscopic Spine Society. He is currently a faculty of the Korean Minimally Invasive Spine Surgery Society. He is a pioneer in endoscopic spine surgeries as well as a noted author and a member of editorial board of several high-ranked journals. He is a member of the board of directors of the World Spinal Column Society. He has received several awards and honors, including the Parvis Cambin Awards in 2018 and Lammy Award in 2019. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Boon Seng from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Masaki Iwasaki.
Hello. So for the first session, we have a lecture from the Professor Giorgio Lorusso. He's going to talk about the surgery for insular opercular epilepsy. So I'm very excited about hearing his lecture because the insular opercular epilepsy is very difficult to diagnose and also the very challenging field in neurosurgery. So could you please start your lecture, Professor Russo?
Okay, thank you. I try to share my screen. Thank you for your kind invitation. This is an honor for me to share my experience with the colleague above all, with Professor Iwasaki, that is an expert in this field. Insular opercular surgery are demanding surgery. We all know where is the enigmatic insula of Ryle, of course, buried in the depth of the lateral fissure. After the pioneering attempts, insular resection for epilepsy were abandoned, where the MNI group reported that adding insular resection to temporal lobectomy did not increase epileptic control, but provided a high surgical morbidity. Indeed, the insula is a hellish place for the neurosurgeon. It is covered by the suprasylvian and temporal opercular, which interfere with the surgical access, It is protected by a dense vascular screen represented by branches of the middle cerebral artery, and it is close to essential cortical and subcortical structures. Nevertheless, the interest toward insular epilepsy surgery has progressively grown in the last decades, as testified by the increase in studies published on this topic. Similarly, procedure with insular resection have significantly increased in the last decades, as happened in our center. This is probably explained by several reasons, but an essential factor is represented by the progressive spread in the use of stereo EEG and of the development of robotic techniques which are ideal for insular sampling. Indeed, because of the complex functional organization and the consequent proteiform semiology of seizure involving the insula, which deserve the nickname of a great pretender, the only way to correctly explore its cortex is by means of intracerebral electrodes. Here, the two major approaches to the insula by means of stereo EEG electrodes. The lateral one is a shorter path, but major vascular intersection are in the parts, and the oblique one with a longer path, but a minor vascular intersection. And here a real example how we can sample from the insula by means of the two approaches. Which one is preferred by epileptologists? Well, this is a good question. It seems the lateral approach for reasons that we can discuss perhaps later. But back again to what the literature can teach us. In his chapter on insular surgery from this book on epilepsy surgery, Masco stated that in a recently reported series of insular cortex resection, isolated insular cortex resections without opercular resection was rare. This statement is corroborated by just reading the title of a more recent paper on this topic. And this paper, from a group with a large experience in insular surgery, reports that only a small proportion of cases with insular resection received a selective insulectomy, 11% of cases. Okay. The same happens in our center. Selective insulectomies were performed in only 6% of cases, mainly lesional, while 2/3 of cases were insular resection with operculectomies in various combinations, suprasylvian, temporal, or both. Indeed, pure insular localizations, as in this case, are rare, compared to insular opercular approaches, as in these cases. But why do we perform so many opercular insular resection? The first reason is that most lesions in this area involve both the insula and the adjacent opercula. Here we have some examples: focal cortical dysplasias in the upper row and glioneural tumors in the lower boxes. I will therefore show the first case, a 47-year-old man with a seizure since infancy and a cortical dysplasia located mainly in the short gyri of the left insula and in the corresponding operculum. The left sylvian fissure for orientation is shown, splitting the fissure to gain early control of the insular plane. Yeah. Then progressive resection of the lesional central operculum with increased exposure of the short gyri and subsequent removal of the lesion and insular cortex by using smooth dissection and ultrasound. Okay, this is the final result. The second case is a 35-year-old woman whose seizure started at 8 and a focal cortical dysplasia involving the posterior portion of the long gyri and the parietal operculum in the right side. Sorry to start the video. Okay. This is a highlight of the lesion. In the planning scene, we can appreciate the close relationship of the lesion with the pyramidal tract and the thalamocortical tract. The strip is positioned on the motor cortex under the dura to obtain the motor evoked potential. Here. Placement of strips in the operculum with difficult to recognize epileptiform activity. But the EEG mapping with intracortical electrodes at different sites in the operculum allowed us to recognize a prominent continuous spiking typical of type 2 focal cortical dysplasia. This is another sample in another part of the operculum, the same activity. And this is a third sampling. We started opening the posterior aspect of the sylvian fissure. We expose the long gyri. Perform an inspection of the sulcus between the long gyri. With identification of the middle cerebral arteries branches, try to not retract or risk of avulsion of perforating arteries. Then performed the operculectomy and resection of posterior and anterior long gyri. Then we use the navigation to check the position, even if with the cerebral shift there is something not working. And with the monopolar probe to define also the distance for the corticospinal tract. Performed a further mapping of the unremoved operculum with the residual activity And so we proceed on with further resection till the last check here. With no spiking more, so the surgery was finished. So a second reason explaining the prevalence of opercular insular resection is that in most cases the hyperelectrogenic zone involves both insula and operculum. This evidence has been strengthened by the use of stereo EEG, as reported by several studies. Here we have the conclusion of some of them, that is that pure insular resection were never performed in the reported cases based on stereo EEG results. Here we have an example of a stereo EEG-based insulo-opercular resections. A young boy with a pluridaily seizure suggesting a perisylvian semiology. The EEG was concordant, but the MRI was negative. This is the stereo EEG exploration where you can appreciate the extensive coverage due to the fact that insular seizures very often mimic a different perisylvian origin. In purple, the insular traces, and in black, the opercular traces. The ictal discharge starts almost simultaneously in the insula and in the operculum. And then the surgical plan is removal of operculum and insula explored by R and S. So the electrode traced were marked on the cortex. In this case, we decided not to open the sylvial fissure, but to perform an operculectomy between vessels with subial dissection and exposure of the insular plane. Here the branches of the middle cerebral artery, always treated gently and without resection. Perform the control of the superior peninsular sulcus. We proceed with a smooth dissection with the aim to preserve the white matter cranial to insular roof containing essential fibers. Then we perform other windows through the operculum between the vessel, here and here, to reach the insular plane, but trying to avoid important pathways. And there are quite fasciculus here highlighted. The opening of the insular plane, always with gentle coagulation, taking some tissue for histology. Then ultrasound, working always between vessels. Okay, and this is the final result. Okay, and there is also a third reason, purely technical. A transopercular approach may improve the control of the insula in some cases, but surely not in all. The debate is open and depends on the experience of the surgeon. In this cadaveric study, it was demonstrated that insular exposure, that is the area available for resection, the surgical window, the corridor for inserting instrument, and the surgical freedom, the space available for moving instruments, are enhanced by a transopercular approach as compared with a pure transilvian approach. But this paper doesn't consider another very important aspect that I tend to emphasize a lot. Indeed, when the approach to the insula is through the operculum, a double vascular arachnoid leaflet is encountered covering the insula, and so the insular exposure can be much limited. Instead, approaching the insula through the dissection of the sylvian valley can be easier, as only one layer is encountered. Additional concern derives from the venous pattern in the perisylvian areas. Here we have 3 left angiograms. In the first, all the veins run away from the sylvian fissure and do not obstruct its splitting. But in the other examples, opening of the fissure would be difficult without the sacrifice of several veins, with possible clinical consequences. On the other hand, sparing this vein could result in insufficient exposure of the insula. So, in these cases, a transopercular approach could be the only viable option. In order to approach insular surgery in the best possible way, reducing complications, we must follow a few rules. These include strict adherence to intraoperative monitoring. I will be brief on motor monitoring. Intraoperative, the mapping monitoring is obtained by direct cortical stimulation with 2 techniques. The stimulation at 50-60 Hz with a bipolar probe was introduced by Penfield in 1937 for intraoperative functional mapping. This was refined by Ogeman by introducing a biphasic current at constant pulse and by optimizing the intraoperative testing task. The second technique, with a train of 5 stimuli, short train technique, was described by Taniguchi in 1993 and can be applied for mapping and continuous monitoring of cortical and subcortical motor pathways. This method is predominantly applied with a monopolar anodal stimulation cortically and cathodal stimulation subcortically. And as minimal movement remains easily unrecognized in anesthetized patients, evoked potential were introduced in the early 90s for motor pathway evaluation. But not only the intraoperative motor and somatosensory monitoring is essential in insular opercular resection, also the language monitoring. Typically, it is performed in awake condition, but we do not perform awake. So I want anyway to share with you an alternative option for monitoring language under general anesthesia, using a protocol with the corticocortical evoked potential. According to the pioneering works of Matsumoto, the technique consists in the recording of cortical evoked potential by stimulation of remote cortical areas. We obtain a waveform with 2 components. The amplitude of the N1 is the most important for our purposes. Yamao reported the intraoperative use of corticocortical evoked potential for monitoring language during tumor resection in the dominant pericilium area, as well as its feasibility under general anesthesia. This procedure is completely task-free, and the electrical parameters used for stimulation, low frequency and single pulse, are ideal for epileptic patients, limiting the risk of induced intraoperative seizure. In our practice, we position two strips on the cortex of the anterior and posterior putative language areas. As mentioned, the connectivity between these two areas is bidirectional. So it is possible to look for the better response. One may choose to record from the anterior language area by stimulating in the posterior language area, or vice versa, based on morphology, stability, and reproducibility of the potential. And these are the main points of our experience with corticocortical evoked potential. Monitoring of language is feasible in epilepsy surgery under general anesthesia. All the procedures have been completed without intraoperative adverse event. An N1 amplitude decrease within 15% does not have postoperative clinical impact, while a decrease around 25–30% resulted in transient postoperative speech impairment. And some points are still under investigation. We do not know the threshold of N1 drop associated to severe injury of the arcuate fasciculum and to permanent speech deficit. And we are also implemented evoked potential recording by subcortical stimulation. The final point is the safety profile of this kind of surgery. In this recent study, we reported that the odds of developing severe neurological complication was 5 times higher for patients undergoing insular opercular resection compared to other locations. So this higher risk of neurological deficit must be taken into consideration when counseling patients who need this surgery. Anyway, in our hands, the rate of patients with neurological morbidity for insular opercular surgery is around 7–8%. Interestingly, this rate has progressively decreased in the last years, probably due to growing surgeon experience, advanced pre-surgical planning, and implementation of a rigorous intraoperative monitoring protocol. The most feared risk is represented by ischemic injury. The signs highlighted by the arrows are frequently present in postoperative MRI after insular and opercular resection. It is not an unwanted extension of the resection, but the result of an ischemic injury. And you can see by the picture in profile of the MRI how it can affect the corticospinal tract. Ischemia is due to injury to low caliber perforating arteries, which arise from the middle cerebral artery branches, perforate the insular cortex or the cortex at the level of the superior perinsular sulcus, and perfuse deeper structures. Most of these arteries have a short course, and they supply a territory limited in depth to the external capsula. But a limited rate of these arteries have a longer trajectory and can supply the corona radiata. The most posterior of them have higher chances to perfuse the corticospinal tract, and their injury increases the risk of motor deficit. And this posterior superior region is for me the most feared and risky region, and this kind of surgery above all in the dominant hemisphere. The problem is that the presence and location of these branches usually is very difficult to be detected preoperatively with routine vascular imaging. Anyway, we are doing attempts to highlight these branches. According to the school we derive from, the Saint-Étienne School of Paris, we perform angiography in every patient we operate for surgical planning. We try to study the angiography with stereoscopic projection, looking for the presence of medullary branches to be spared, perhaps the very little branches indicated by the arrows. And on the other hand, we are interested in the way how we can recognize these branches intraoperatively. As even intraoperatively, their identification is really problematic, if not perhaps by means of the injection of contrast media, or I say in Indochine, Flow 800 Doppler, with the technique of Professor Iwasaki of the temporary clipping to define which artery supplies the cortical spinal tract. I think that we will try to check this technique, even if we are afraid of possible risk linked to the clipping of those arteries. Or perhaps preserving the gray matter at the level of the preinsular sulcus. This could be a good attitude, a good strategy, useful to limit injury to this vessel, as shown in the red circle. Also from this picture, you can get another indication of the advantage and risk of the transopercular approach compared to the transsylvian. By opening the sylvian scissor, you can recognize the superior circular sulcus of the insula and better manage what to do. Whereas with a simple transopercular route, the risk of injury to these very branches is not negligible. But at this point, I think I must stop boring you, as I have already taken up too much of your patience and time. So I thank you for your attention.
I thank you very much, Professor Russo. This is a very beautiful lecture, and also you showed very beautiful videos too. So
at least I succeeded. You know, this was a big problem, but at the end,
yeah, that was very finally very good. Yes. There's one question in the QA field. I read. So what is the extent of resection, and where do you stop during the insulectomy?
Well, this where I stop, meaning the extent of the resection, I don't think that the question is into the depth. But when we stop in resecting the insular surface, well, you know, it depends on the approach. If the approach is to cure a lesion, to resect a lesion, the limit should be detected by the extension of the lesion. If the lesion is covering the space of the short gyri, for example, we try to limit our resection to the short gyri. Or differently, if the resection is guided by the stereo-G, then we have to comply with the result of stereo-G. Stereo-G is very, very precise in telling you where are the anomaly, the epileptiform anomaly, and the ictal onset zone. We can interpolate between contact, as of course you can't cover all the insula. We can interpolate, but by this means we have to decide. We can decide to what happened. Those are the pictures that I showed in my presentation. It can happen that only the long gyri are involved, so we limit this to the long gyri, and so on. As I show very often, also the opercula are involved. So according to the extension of the resection of the opercula, we decide the extension of the resection in this.
Okay. Actually, I have one question. What do you think about the role of stereotactic ablation surgery for the insular surgery? Do you only perform open surgery?
Well, you know, something a mix. I see what you mean. You publish a very nice paper. You were the last author with the volume-based radiofrequency thermocoagulation of the insula.
Yes.
You mentioned it. Okay, we are trying something like this. When we perform steerage anyway, we use to thermocoagulate
Yes.
the place where we found ictal onset zone, ictal activity, and the place where the electrode is not so close to vessel. That is always, of course, a problem in insular surgery. Instead of open the scale approach the insula directly, sure that in some cases the thermal ablation, the LIT, the volume-based radiofrequency thermocoagulation can work very well. I am afraid of the consequence on the vessel thermocoagulation, but I have to say you that other people I saw ablation made by radiofrequency in Paris by our friend Bertrand Devaux. I saw many ablation in paper published, and apparently this risk that we feared of coagulate, of course, the cortex, but also the vessel, seems not so important. So I think that it should be a very good tool to try to coagulate in given cases the cortex of the insula. I saw that you can shape the coagulation so to reach more or less all the extent of the insula. So we have not the same experience, unfortunately, but I think this is a very, very good approach.
Okay, thank you. Is there any comment from, for example, Dr. Lu? Do you have any comment?
Yeah, thanks, Professor. Thanks for a very excellent talk, Professor. I have two questions, Professor. One is actually regarding the use of CUSA, because I saw you using CUSA for the corticectomy, and even on a small perforator, it doesn't cause bleeding. May I know what setting do you use for such delicate work with CUSA? Because one of your we're touching the vessel without bleeding, a deep vessel. My second question, Professor, is something new for me, the cortical evok potential for the speech preservation. May I know that with such monitoring, do you need a bigger craniotomy rather than the craniotomy confined to the area of focal cortical dysplasia? And if we are going to do that, can it be replaced rather than to have the grid electrode to use the scup electrode? Would it be useful if you want to convert into a smaller opening? Actually, I have one more last question, Professor. Do you use ultrasound to correct the brain shift? Thank you, Professor.
To answer to your last question, no, we don't use ultrasound to correct the brain shift. Actually, with our so-called repérage, we recognize on the surface the shape, the source of the vessel, so we do not need actually the neuronavigation. We prefer more the recognition of the surgical surface. And we use the navigation into the depths, where there are no other landmark. But anyway, also the neuronavigation with the shift of the brain is not so good. On the level of the insula, we prefer to look for the vessel that we know very well because we perform the angiography. So we orientate with even there, that is a cortex, the insular cortex, we prefer to go with the landmark that we know with the vessel. The other question is if we need a larger craniotomy. Yes, sure. We need a craniotomy that try to expose the so-called Broca area and vernix area. But anyway, it's not so big because very often the same happen with the motor cortex monitor, to motor pathway monitoring. We slid the strip under the dura, between the dura and the cortex, and this can be also useful because in this way we can stop the strip between the dura and the cortex. So is useful to have a craniotomy not so large to expose all the brain, but just the entrance to allow the strip to be positioned under the dura. Anyway, I am well. I don't know to speak of another problem. Perhaps you know for what concern the hemispherotomy, a paper of Johannes Schramm of Bonn, in which he showed a craniotomy, a very small craniotomy, through which he was able to perform an hemispherotomy. I prefer a larger craniotomy. I prefer to see what I am doing, because the best for the patient is not having deficit, not having a smaller or larger craniotomy. This is my opinion.
Yes.
Thank you, Professor.
Yeah, I agree with your opinion too. Okay, is there any other questions?
Well, thank you very much, Professor
Okay.
Luruso. May I ask
Thank
you
you.
one question?
Okay, thank you so
One
much.
question single from me.
Oh, your
Like
question.
when you are going on resecting and you reach very near the basal ganglia in the deeper aspect, what is the visual clue to get that you have reached there, other than neuronavigation? Because neuronavigation may not be available in the low and middle income countries, because as you exceed your resection more medially, you reach a landmark where there is basal ganglia and the extreme capsule. And how do you know that? Is there any visual clues there?
Okay. Well, you know, epilepsy surgery is not tumoral surgery. So, in principle, you have to stop after the gray matter stop in the white matter. You are in the external capsule. So this is a visual inspection, and no other. You have no other tool in my opinion, because with the installed with the neuronavigation, we are already into the basal ganglia with the neuronavigation because of the shift of the brain. So we try, of course, not to damage the lenticulostriate arteries when we approach the anterior insula. We try to see them, but otherwise is a visual inspection that allow us to pass the depth into the depth, the cortex. There was I showed one of the cases, the so-called pure insular case that I showed was a ganglioglioma inserted into the insula. And there you can define your section by the morphology, by the characteristics of the tissue that was very, very hard. So anyway, it was a tissue that you have to take out, but always with visual inspection you decide this, if I well understood your question.
Thank you very much. Now may I request Professor Masaki Iwasaki to conclude this session.
Okay, so yes, Professor Russo beautifully presented the actually the reality of insular surgery. So yes, we need to maximally use the intraoperative monitoring to minimize the risk of the for example, motor deficit. Then yes, you can perform safe surgery. So which I learned a lot from Professor Russo. So thank you very much, Professor. Okay,
thank you.
We are going to close the first session. Thank you so much.
Well, thank you very much. That was indeed a wonderful session, and we learned a lot about opercular insular epilepsy. Professor Masaki Iwasaki and Professor Luruso, thank you very much for this wonderful session. I'll give this podium to Professor Harrison Kim, who will say a short introduction, and invite Professor Tandon for his lecture. Professor Kim, all yours.
Thank you so much. Hello everyone, I'm Hyun-sung Harrison Kim from Gangnam Nari Hospital, Seoul, South Korea. My curriculum was already introduced by Dr. Raja Krishnan, QT, and very thanks to introducing me. And we listened a very beautiful and nice lecture from Professor Russo and a comment from Iwasaki. Thank you so much. Your great lecture, Professor Russo, and great comment of Professor Iwasaki. And now we will move from brain to spine. Actually, with the development of endoscopic spine surgery, the portion of the neurosurgery will be increases so much, and the importance of neurosurgery very increased due to the neurosurgical skill is very helpful to developing endoscopic spinal surgery. And also the endoscopic spinal surgery before time, there is not major part in the neurosurgical part, but with the people's midlife increase so much nowadays, the endoscopic spinal surgery become a major part of the neurosurgical field, and also among them the endoscopic spine surgery acting very importantly to improving the clinical result. Among them, the endoscopic decompression is the very important portion to popularize the popularization of the spinal surgery with the not only younger people but also some more older people that needed the treatment of neurosurgical support. Because of that, the listening of the endoscopic decompression will be a very important portion. Today, Professor Ashish Tandon will give a great lecture about Uniportal endoscopic lumbar decompression and discectomy. He will talk about the basics and the video presentation. Professor Ashish Tandon.
Thank you, Professor Kim. It's an honor to be speaking besides you. We have seen a lot of your surgeries and your work, and gone through a lot of your publications as well. In fact, in one of my slides, I'll be sharing your very important publication, which I would request all the students to go through. though my lecture today is focused on interlaminar, but they can read about transforaminal as well as interlaminar in your narrative there. Once again, thanks to Dr. Raja and team for this invitation. So today I would be speaking on full endoscopic interlaminar lumbar surgery. And I would be mainly focusing on discectomies and management of the stenosis. The lecture that has been prepared today is very basic for those who are starting and who want to jump into the field of endoscopic spine and lumbar surgeries. Quick few of my disclosures. Almost 60% still of my spine work is tubulars. 30% has gradually shifted to interlaminar full endoscopic, and this percentage is progressively increasing. However, still 10% of my cases fall into the category of microdiscectomies and transforaminal discectomies. The other important thing that I want to mention is for canal stenosis, I use a larger diascope, which is shorter in length. However, almost the same set of equipment as for transforaminal discectomy. I have had my fair share of failures and complications, and I must emphasize here that there is a steep learning curve, especially in handling the instruments when it comes to endoscopic interlaminar procedures. The full endoscopic interlaminar technique has been made possible because of one, development of efficient working channel and efficient burrs and rongeurs. So this has sort of catapulted endoscopic interlaminar surgery. The following are my indications. So I would go in for a lumbar discectomy L3-4 downwards. So L5-S1, L4-5, and L4-3 PIVDs. Calcified disc, I would prefer going an interlaminar approach. Highly migrated discs that are not amenable through a transforaminal approach, I would readily go through a interlaminar approach. Central canal stenosis, lateral recess, and a few types of spinal canal cysts as well. So I would typically deal with an L5-S1 or L4-5 migrated disc or a hard calcific disc for an interlaminar approach. For me, transforaminals would be more of L3-4, L4-5, which have not migrated. And I would, there are reasons for it, and I would come to it later. But there are certain relative contraindications as well for an endoscopic interlaminar approach, and we must all should be aware of these. Previous posterior surgery because of a lot of scarring is a relative contraindication. Disc prolapse at upper lumbar levels because of narrow canal and a need for retraction, not a very good one in that, so tend to avoid at upper lumbar levels. Or in certain cases of extensive facetal overgrowth where, I feel that it may not be good enough. So this is a typical L5-S1 disc. I would go in for a normotensive to controlled hypotensive anesthesia, and I do all of my cases under general anesthesia. But there are a group of surgeons who are doing it under local anesthesia as well, or epidural anesthesias, and there are publications comparing transforaminal and interlaminar as far as the type of anesthesia is concerned. Having said that, I personally am very comfortable using general anesthesia and keeps things under my control. So after the anesthesia, typically position the patient in prone, and then I break the table. Here you are seeing longitudinal bolsters, but now I have shifted to horizontal bolsters and keep the bolster at the level where I want the break. So typically we use this because we know that on flexion, the interlaminar space increases, and we are just utilizing that process for our advantage, and a decrease in the shaving of the spine, the lamina, as well as reducing time. Once we have positioned the patient, would do typical AP and lateral views, and it is important to see to it that you made there is the two end plates, the superior end plates are in one line. So after AP and either you can go through the to the medial pedicle line or in between, but I rather prefer these days going to the medial pedicle line, especially in L5-S1 discs. Once that is done, a single small incision is made, which cuts up to the fascia. And after the fascia is cut, I would typically insert a dilator. And then the dilator goes in through the muscle, reaches to the lamina, the inferior margin of the upper lamina, and you can sort of wriggle your instrument there to, feel the edge, which is a good way. And thereafter, I put in my sheath. This is typically the position I would love here or a little below. So this is the dilator, and in here is the cannula that has been inserted. Once that is done, the scope is inserted. Here I'm using an interlaminar scope, which is for stenosis. You add on a irrigation device wherein you can control the pressure. And thereafter, you start the procedure through the working channel. This photographs I have shown, brought in here to typically show you the position of the hand. Like for many of the endoscopic procedures, you use one hand to hold, and you just have one more, the other hand to sort of do the surgery. So it is not a by-hand technique. However, having said that, a few months back, I had observed my laparoscopic surgeon, and his assistant was holding the scope. And recently, I gave the scope to my fellow, and he was holding, and I was trying to use it with two hands. The load decreased. So we are still sort of trying on that, whether, if you give the scope to your assistant, and if you're doing it, with two surgeon techniques. So we are still not, it is early days for that technique, but we are working on it. Presently, I would say that I'm still a single surgeon two-hand technique. So herein, after this initial briefing, I would come on to my certain of my videos, which on their own elaborate the technique. So here I would start with a case which is a hard disc. Hard L5-S1 disc, which is inferiorly migrated a bit here, and it is more paracentral. Quickly expose, go into the interlaminar space, and thereafter cut open the ligamentum flavum layer-wise. Once the epidural space is visualized, you can extend the opening of the ligamentum flavum bang till the medial facet at L5-S1. At L5-S1, you don't need any sort of facetectomy. You use a simple dissector to push the root and open the annulus. If you already do not have a opening in the annulus through which the sequestrated fragment has come out. And thereafter, you have various types of rongers, which are straight and forward and intradiscal, to sort of complete the discectomy. Personally, I do a little more than just sequestrectomy, and I try to clear the internal free fragments as well. And here you can see the root, the theca. You can easily explore the axilla as well at L5S1. The opening, as you can very well appreciate, is just about 4 into 3 millimeters in the ligamentum flavum. This was one of the larger pieces in this case. Here, I just wanted to demonstrate the extent of decompression. You can move your scope right from above. Here, you can see almost up to above the inferior end plate, and here almost till the superior end plate and a little lower of S1. So you get a lot of space to move your scope. These are simple set of instruments that I use. I use the same set of instruments as for transforaminal mostly, and the scope itself is very similar. Here I would be demonstrating, showing you a case of L4-5 disc, and generally you do need some sort of medial facetectomy using high-speed drill for L4-5 or L3-4. Here, as you can see in this video, I'm just demonstrating a disc which is almost similar or gone a little higher up. Again, same set of instruments that I use, a tube here. And previously, I used to use these types of drills, but now I have shifted to protected sheath and using the shaver system. Again, after you have dissected the root, you just push it laterally, take the advantage of the bevel, and go ahead and perform discectomy. So here, most of the disc was an extruded fragment, and we were able to sort of excise it. Here, this is a forward sort of instrument, disc ronger, which helps in pushing the root as well as at the same time achieve discectomy. So this was at L4-5. This is a recently performed surgery of a 40-year-old gentleman with left radicular pain for 6 months. And here you'll see a good sequestrated fragment which is coming out, which was paracentral and entering into, part of it was entering into the foramen as well. Again, the positioning, confirming the entry. Here, as you can see, the end plates are not quite aligned, but that was because I was not able to tilt it further. Here you can see the lateral, and thereafter the sheath is inserted. So once the sheath is in place, you first remove the soft tissue over the interlaminar ligamentum flavum. You see the yellow ligament. You turn the scope so that you're always able to see the tip of your instruments. And then, as I've already mentioned before, layer by layer, you open gradually the ligamentum flavum. After the initial opening, we generally tend to reverse the instrument and cut towards the medial facet, achieve hemostasis. And here I'm using a dissector. There's multiple sequestrated fragments. So here the dissector is being used to gradually separate out, and forward cupped instruments are used for plucking these out from their position anterior to the root. So multiple of these fragments were removed, and a few were large and needed some mobilization. Following radical discectomy, or rather sequestrectomy, we then went inside the disc for any free fragments. So here you will appreciate that the root, this is the root which is extremely red, inflamed. here we have sort of the sheath is protecting the root, and we are pulling out the sequestrated fragment from under the root. So here, this was the opening in the annulus through which the sequestrated fragments had come out, and finally internal decompression to complete the procedure. These patients can typically, here you can see the free root pulsating quite well. A single stitch. Just wanted to share quickly on the hemostasis technique. So you need meticulous surgical technique, which is important. Use radiofrequency probe, which works very good under the water, or irrigation, continuous irrigation under pressure. Especially if there is bleeding, you can just increase the pressure, but at no time the pressure should increase or go beyond the diastolic blood pressure. I've read about certain reports where they supplement irrigation fluid with 1 milligram of epinephrine per 3 liter bag. I personally don't use it, but this is what is mentioned in the literature. A final video of stenosis. As you can appreciate, there is thick ligamentum flavum and stenosis in here. Again, all black on the axial. And here it's a interlaminar discectomy as well as decompression using a large scope. The right side. So this is cranial here, and this is caudal, lateral, and medial. So again, initially using burrs to do laminotomy. This is an ipsilateral over the top decompression. Here, drilling the base of the spinous process, opening of the ligamentum flavum. That is basically a standard technique. But in here, we bring in upcuts more often to sort of decompress. Here I have gone over the top, so here you can appreciate the theca, and here. So I am on the right side, and at this point of time I am doing over the top decompression on the left. Here you can see I am doing foraminotomy. The root is going in. Here trying to demonstrate decompression of the right, and thereafter undertaking discectomy, and finally here you can appreciate the right side root, the axilla in here. So you can very well do an extensive decompression. Because the channel is bigger, you don't take a lot of time vis-a-vis the smaller scope. Here, just wanted to again show you the extent of decompression in a 10 millimeter incision. This is the post-op to show the extent of decompression. So this is the post-op that we have been able to achieve. This was an immediate post-op MRI. Now, quickly, a few slides on the comparison of two endoscopic spine surgical techniques. This was Louis Sebin et al. And what this paper suggested was, although both endoscopic techniques compared, when I say both transforaminal and interlaminar, they're both safe and effective for surgical treatment of lumbar herniated disc. However, the interlaminar technique presented significantly better results and lower rates of complications than transforaminal. This is another recent publication, outcome of discectomy using full endoscopic visualization. And there's a brief comparison of interlaminar versus transforaminal. And here they highlight that the mean operative time and fluoroscopy time in the interlaminar group is significantly shorter compared to the transforaminal group. Again, comparison between endoscopic and microsurgery. This paper is from Rutten et al., who really started off the interlaminar endoscopic movement. And they had their study of almost 200 cases. There was decreased post-op pain, less requirement of analgesics in the endoscopic group. Again, reduced post-op work disability in the endoscopic group, and there was similar rates of recurrence. So you are comparing it with the gold standard, and sort of it is, at least this paper highlights that it might be a little better. Again, this paper is by the chair here, Professor Kim. I would strongly recommend all of you to go through it. It's a narrative review in neurospine, development of full endoscopic lumbar spine surgery. So to quickly conclude, interlaminar approach, the advantage is it's a known anatomy vis-a-vis transforaminal. You have learned this, gone through this approach day in and day out. The learning curve for handling the instruments is there, and it is quite steep. So one should be aware of that. You can deal with all types of disc herniations as well as lumbar canal stenosis L3 downwards. I use typically 2 different types of scopes and sheets and instruments. And it's an evolving technology with, I personally feel that it has the potential, and it is coming out strongly as the workhorse for this type of surgery. Thank you so much.
Thank you so much, great lecture, Professor Ashish Tandon. Your lecture is very nice and fantastic. Here I have 2 questions from the message. Dr. Harshad Parak, you have 2 questions. The first question is that maybe you can, in the spinal stenosis, combined with the spinal stenosis, what kind of, do you doing the endoscopic decompression? He already commented there, but you gave the lecture. Because of that, I think that maybe he deleted the comment, but can you comment how to decide the decompression or only discectomy in the intraluminal approach for degenerative pathology? For example, some patient only a disc protrusion that needed a discectomy, but some patient that have a radiculopathy, but mainly combination with the disc and stenosis pathology together. The patient maybe sometimes need a decompression discectomy together. What kind of your option?
Well, definitely there has to be a clinico-radiological coherence between what your patient is presenting and what you entail to achieve. Having said that, if the prominent pathology on the MRI is a disc, I would go in for a simple discectomy. But if there is an element of stenosis, lateral recess, I may go for a more extensive ligamentum flavum opening. But in case where the stenosis is predominant, then I would shift to the primary surgery would be stenosis decompression with foraminotomies. Because if we have not done that, then the patient may not achieve complete relief, just merely by discectomy.
Okay, thank you so much. And also, Dr. Harshad Parke gives some more question. Do you encounter the root injury or dural tear during the operation?
Oh, yes. Not with lateral recess or lumbar canal stenosis, but during my initial learning phase, I have had some dural tears, but mainly those tears have been towards the root and not in the primary theca. So I have had that, but we've just managed it using Duragen. In this group of my patients with this complications, with this complication, I have found that radicular pain generally resolves a little late. It does resolve, but it takes a little longer time.
Actually, in the endoscope decompression, we can easily match the dural tear, and also some Korean expert doctor and me together. Recently, also I encountered some dural tear, but fortunately, the endoscopic decompression for spinal stenosis dural tear is very easily managed by the tacosil blocking technique. I already published that technique in the World Neurosurgery. I think that maybe the working space very narrow. Because of that, we apply the patchy that is easily some blocking the root prolapse and CSF leakage. Because of that, I recommend if you met some dural tear during the endoscopic decompression, you try the tacosil application and take some bed rest. That usually have no problem in the after some walking. In my experience, maybe I have more than 1,000 cases of on endoscopic decompression. That cases I only need some open conversion of dural tear is only 2 cases, meaning that the very low chance of to convert to the open surgery.
Yeah.
Yes. Okay. Have any question in the floor?
Yes. But first of all, let me thank Professor Ashish Tandon for showing us such wonderful videos, and they are extremely
I have one
educational.
question.
Yes,
One comment.
please.
Yeah. Yes. Intramina, Ashish already talked that some paper talking that some intramina is more good compared to the transforaminal approach, but as endoscopic spine surgeon experienced more than 20 years, and I completely agree the comment of the Professor Tony Young. Actually, the real mind of endoscopic spine surgery is it's a real preservation of the structure rather than they're also very important to take a good clinical result, but more importantly, with the together, structural preservation is very important. Because of that may affect the longer follow-up result, clinical result of the degenerative spinal disease patient. It means that in my experience, I recommend, if it's possible, to the transforaminal approach, but maybe I already mentioned that with the development of the old age, the spinal disease increased so much, and together stenosis combination, the pathology also increased so much, meaning that the transforaminal is a very nice technique, but so many patients need some posterior approach of the discectomy and decompression together. Because of that, some experts, the intraminal approach is also very important to processing the next generation of the endoscopic spine surgery, not only decompression of lumbar, decompression of thorax, and decompression and cervical, and the lumbar intervallic fusion. That also, in my opinion, all changed from the endoscopic intraminal approach. Because of that, today's Ashish Tandon's lectures are very fantastic. Yeah.
Yes, it is indeed fantastic. One question I would like to put across to Professor Tandon is, sometimes, in some cases, you have a lot of engorged venous plexus there in front of the disc, like L5S. What do you recommend when you have that?
So basically, there are a few things that we have changed. One is from the vertical bolsters to the horizontal bolsters. I can assure you that placing horizontal bolsters has decreased the epidural congestion by, I mean, it is quite gross. That is just about the position. But in case if you find internally, because of a lot of irrigation that you're doing, what we see in microsurgery, where you have large dilated vessels, here the chances are a little less of finding those engorged vessels. But even if you find them, then you have RF probes. And because the RF probe gets angulated, it can, and as we know that epidural plexus is more towards the lateral side. So you can easily, buzz those epidural vessels there. So I think managing epidural vessels and their engorgement is in most of the cases, pretty straightforward.
Thank you very much. Yes, my co-host Libun Singh, any questions?
Yeah, then you have any question?
Yeah, thanks, Professor, for a very good lecture. I have two questions, Professor. Your lecture is talking about pure endoscopic approach for maximum so-called structure preservation. What's your opinion regarding biportal technique, so-called endoscopic assisted? Will you think the same tissue preservation will be able to achieve or differently? My second question, Professor, you did mention that it's important to see the tip of the instrument when you do discectomy. And I believe that you always use 30-degree scope. Is it true? Or do you also use 0-degree scope? If so, when do you use it? Thank you, Professor.
Okay, so I'll answer the second question first. It is obviously a 25 or a 30-degree scope, but still, when your scope is looking in front and the instrument goes from front. So what happens is, though it is a 30-degree scope, still your instruments can be blinded. So the typical way to do is just turn your scope so that you are able to see the tip. So it is just a gradual angulation of your or rotation of the scope to see the tip, and that is very important. You can't just do your surgery blindly. So that was to answer your second question. And I personally don't use 0-degree scope, so I have no experience. I just use 25 and 30-degree scope. So that is the second. What was your first question? I'm sorry.
Yeah, biportal with the degree of tissue preservation. Yes.
Yeah. So what I feel is, biportal is another add-on technique. But with biportal, I personally feel that the instruments are engaging with each other. And I don't have much of an experience with biportal, and I'm fairly comfortable doing it with the uniportal technique. Because
can I comment on more?
Yeah, please.
Actually, the real advantage of endoscopic uniportal for endoscopic approach is we know that there is minimized option is advantage, but actually, real advantage is that real mobilized and first, and second things is real deeper and more clear deeper. It means that in spite of the more deeper and more corner side, more easily approach by the mobilization of the working channel. Ashish already talking that. Because of that, if we expert the uniportal endoscopic spine surgery, we can all cover the biportal technique. Because of that, we very easily accept a more deeper point. But the only problem is that some learning is more difficult. Is that? Yeah, and also I already mentioned. Yeah, I already mentioned that structural preservation. Before time, we don't think that is not important, but nowadays we know that structural preservation is very important in the endoscopic spine surgery for degenerative spine disease to preserve the stability and return to their activity, their spinal alignment. That is very important. Because of that, we need a more minimized approach to the spine.
I would also like to state one thing in here for people who are about to start, that the handling of instruments is extremely important with any sort of endospine, because these are very fragile instruments. You know, when we started with the open, we were rough. When we shifted to micro, we became a little softer. When we shifted to distando and tubular, we still became more softer, and instrument breakage rate were higher. Instrument breakage rate is extremely high if you are not very cautious with the uniportal endoscopic technique. And so you have to be extremely careful of what exactly you are doing and how you are handling the instruments. So this is a very important aspect of this type of surgery.
Thank you very much, Professor.
Okay.
And here the
Dr.
concluding
Raja?
remarks. You may say your final remarks, Professor, and we will end this.
Yeah, I think that maybe we have a sufficient talking about some insular epilepsy and uniportal endoscopic decompression. Thank you so much for a great lecture and for all attendees. Thank you so much.
Thank you very much. So I'll end this officially now on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Giorgio Liruso and Professor Ashish Tandon, as well as the chairs, Professor Masaki Wasaki and Professor Yuang Seng Kim, for the time and support for the ACNS webinars. A special thanks to my co-host Liu Bun Seng for joining me today, and extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. So until we all meet online on next Saturday, it is bye-bye from all of us. Thank you very much for joining.